Okay. Good afternoon. Master Jean has arrived, so we can start.
I'm sorry.
I think that we are in the tool and technique session. You can still leave the room or join the room. And the topic is left main bifurcation treatment with ultra-thin Supraflex Cruz stent. And we will go from non-invasive imaging angiography to invasive assessment of anatomy and physiology. And I would like to introduce the people in the panel, in the studio, and eventually in the audience. I am Patrick Serruys from Galway, Ireland, and I will have the first slide. First, that's my conflict of interest. The people here is Jean Fajadet, which is a retired cardiologist, but very busy with robotic PCI. We have as a discussant Praveen Chandra from the Medanta Hospital, New Delhi. Joanna Wykrzykowska, did I say it well? Okay, from the University of Groningen. Alessandro Beneduce from the Clinique Pasteur, colleague of Bruno. And then as a discussant, we have Pruthvi, Revaiah, University of Galway, and John Tsai, University of Galway also. The key question and objective of today is to learn how to assess anatomy and physiology of left main lesion on non-invasive imaging, to appraise how to choose the optimal left main bifurcation stent strategy, and to appreciate how to optimize left main stent results based on intracoronary imaging. Of course, we have multiple modalities shown on this slide. You can use the angiography, the conventional angiography. You can involve IVUS technique, QFR, OCT, and CTA. That will be for the introduction. We will see at some point how we use the intracoronary imaging, probably at the end of the case to optimize the left main if it has to be optimized. And we will use in this case the OFDI of Terumo. And we are very fortunate to have a great expert in the cath lab in Toulouse, that's Professor Yoshinobu, also from Galway, which will analyze the OCT for us at the end of the procedure. In this session, you are about to see what we call a multi-modality approach and how to reestablish a good hemodynamic of the bifurcation. And as I said, that include CTA, angiography, and OCT. Jean?
No, thank you, Patrick. And the role of spokesperson, I would like to tell you that you could use the microphone on the alley or ask questions direct on the plaque. It's an interactive session, so you can interrupt us at any time during the session when we have something which is not clear, something that we want really a clear explanation what we are saying. Do not hesitate. Microphone or application, I will do my best to reply.
Thank you, Jean. So I will have to introduce Alessandro Beneduce, who will present the case for us. Alessandro, the floor is yours. I'll push the button for you maybe and move to that. And that should be okay.
Thank you very much. And welcome to this session. And thank you for being here late this afternoon. I'm sure you will not regret this decision. So let's move on with the case presentation. Today, we are dealing with an 81-year-old gentleman without a significant previous medical history who presents to our attention due to crescendo effort angina, which is now in CCS class 3. His physical examination, laboratory findings, are unremarkable, with normal hemoglobin, normal renal function, and normal troponin and NT-proBNP values. The ECG at rest does not show any sign of ongoing ischemia, while the transthoracic echocardiography shows a normal left ventricular ejection fraction. So, based on the symptoms, on the pretest probability of CAD, and also on the clinical likelihood of CAD, we decided to offer this patient a multi-slice computed tomography as a diagnostic test, which revealed a 60% calcified stenosis of the distal left main. Therefore, we moved to coronary angiography, which demonstrated slight mild disease in the right coronary artery, and which confirmed on the left side a significant stenosis of the distal left main, showing also some mild disease of the mid-LAD involving the diagonal branch. So based on these angiographic findings, we are dealing with a patient who has an angiographic syndrome score of 20, a syntax score 2, which shows equipoise between PCI and CABG, and who has a low surgical mortality risk. Therefore, based on these considerations, after heart team evaluation and discussion with the patient, we decided to offer him PCI of the left main. So to summarize our key clinical and angiographic data, we are dealing with an 81-year-old gentleman who is symptomatic for angina, CCS class 3, who has a preserved left ventricular ejection fraction, and has a significant stenosis of the distal left main, a bifurcation stenosis Medina 100, and has an overall syntax score of 20. So based on these findings, we kindly ask Professor Serruys to assist, and his team in Galway, to assist us with multi-slice computed tomography analysis.
Thank you. Thank you, Alessandro. We will have now John Tsai from Galway, which is going to review for you and for us the multi-slide CT scan of this case. Good day. Okay, John.
Good afternoon, everyone. Today I'm going to talk about a diagnostic multi-slide CT scan and the CT-based planning for PCI of this patient. So this patient received a CT scan from a Siemens scanner with very high quality, 0.6 millimeter per slice. To the left, this is a volume rendering hologram that you can get a general picture of the anatomy of the patient. You can appreciate there are some calcification over the left main, and you can also refer to the right hand that you can see in the maximum intensity projection that there are some calcified plaques over the left main bifurcation. There are also some calcium in the right coronary artery and the LAD itself as well. So we finish with an overview. Now we take a closer look at the right coronary artery. In this maximum intensity projection, as well as this multiplanar image, you can appreciate that there are some non-obstructive stenosis in the middle of right coronary artery, as well as some plaques in the distal of right coronary artery. There are some calcium over there and there, but as you can see in the FFRCT, the lesion is not causing significant stenosis. So we can now focus on the left main bifurcation. The angle between the left main bifurcation in the LAD and the circ is 78 degrees. You can see now that it's very calcified. So now, from now on, we are going to take a slide-by-slide closer look at the cross sections of the left main bifurcation. First, we look at the proximal of LAD, where you can get a healthy zone with a reference lumen diameter of 4.3 in millimeters. And then you go to where the lesion is, the left main distal. You can see that it is nearly 330-degree calcified plaques that's in this cross section, with a minimal lumen diameter of 1.2 millimeters and minimal lumen area of 3.24 millimeters square. The diameter stenosis is 71.4% in our analysis. Of course, that lesion also goes into LAD proximal. Here in LAD proximal, the area is 6.767 millimeters square. And when you go all the way to the LAD middle, you finally hit another healthy zone that is with a reference diameter of 2.98. And we take a look at the circ. At the circ ostium, the left main distal calcified plaque, of course, also extend to the circ ostium, where you can see the minimum lumen area of 3.03 millimeters square at diameter stenosis of 38.7%. At the circ distal, you see the reference diameter of 2.73. On the FFRCT, the LAD is very ischemic with FFRCT value of less than 0.5. For the circ, is 0.55, right after the left main distal. So in conclusion, this left main bifurcation with an angle of 78 degrees, you have a minimum lumen area of 3.24 and a proximal and distal reference area of 4.3 and 3.0 respectively. The length of this lesion is 25.1 millimeter. So with this information, we can calculate the syntax score. Based on the CT anatomy, you can calculate that the syntax score, anatomy syntax score is 24. And take a look at the multiplanar of the left side. You can appreciate that we calculate the left main and the LAD lesion. With the app that is provided by the SMT, you can input clinical information and get the Syntax 2020 to get the 5-year and 10-year MACE rate. For 5-year MACE rate and for 10-year mortality rate of this patient, you will find that this patient also have nearly identical 5-year MACE rate and 10-year mortality rate. So you can see here that we do a detailed reappraisal of the FFRCT for this patient, and we are also trying to find the best angle that we are going to use for PCI. For the left main ostium, that we suggest the operator to use the LAO 20 and cranial 30 degree. And for the left main bifurcation, we suggest that they use the LAO 50 or caudal 35. So what's the strategy for the left main PCI of this patient? First, we take another time the overall view of the calcium. So we see some calcium in the left main, and we measure the sinus of Valsalva size is 2.88. So we need something supportive with 7 French, and with this 2.88, we probably need a 3.0 supportive guide. And to the device selection. So with this left main bifurcation with mainly calcified plaques that also extend to somewhat into the LAD and the circ, we probably need some plaque modification. With the minimum lumen area, we know that is 1.2. We probably can go up to 1.5, 1.75 in with a rotablator if you want. And also you can use, with the reference diameter, you can use a 4.0 lithotripsy balloon. The working angle again is LAO 20 and cranial 30 for the left main ostium, and the left main bifurcation working angle is LAO 50 and caudal 35. So let's select the stent. Based on the knowledge we have from the CT, the distal reference of around 3.0, we suggest that you can probably select the 3.0 over 28 millimeter stent and pot it with a 4.5 millimeter balloon. Thank you.
Thank you very much, John. That was a beautiful analysis of the situation.
Sorry. I forgot to mention with a FFRCT PCI planner, we also can calculate how much FFRCT you can get after the PCI. And for this lesion, you can get a 0.94 at LAD middle. Sorry.
That's very important to anticipate a little bit the future. Very good. Thank you very much. Jean, I think you have questions. So we are going to leave a little bit the script and make some improvisation.
There are 2 questions. One is concerning the Medina classification by angiography or by imaging. Any difference? Same?
Who wants to respond that? Why not John? Short response.
So for the Medina classification, it's also used 50% stenosis of the, and so in the CT, although you can see lesions all over the place, you are after all looking at stenosis. So the classification is the same.
And the other question, thank you. And the other question is, did you consider CT-FFR after seeing 60% stenosis on CT?
Keep going.
Okay. So in our workflow, we have the CT and we do the plaque analysis and the multi-planner, the overview, the planning, and we also send that to do the CT-FFR. It does not matter how much stenosis we have, but CT-FFR does provide some additional value, especially for the equivocal lesions that you may not know that whether it is stenotic, it is causing ischemia or not. And sometimes the CT-FFR will also show you that maybe these lesions, the coarse lesion CT-FFR drop is maybe not big enough according to the CAT-RAS 2.0, that maybe this lesion you may not need to treat it. And with the CT-FFR CT planner, you will know how much FFR CT you are getting.
The last one, very short before giving the floor to Joanna. It's do we have any study for comparison of CT and IVUS in assessment of severity of lesion?
Yeah, I think there's a couple of studies ongoing, right? I mean, there's Carlos Colette is busy with guidance with CT versus IVUS to compare the two techniques. But
I think that at the very end, we will show the evidence, and the evidence has been reported in the New England last year. It's a work which has been done between, you will see on the slide, between 2015 and 2019 in 26 centers in Europe. There's a 48 months of follow-up which has been published, but I will show you that at the very end. That's the evidence. That was the question. Jean. You had a question for Joanna, how she's going to treat that vessel.
The treatment has been actually laid out perfectly for us. So I think the key here is that based on the angio, I probably would say circumflex is not so sick. Calcifications are mild to moderate. I would probably go for predilation, provisional strategy with one stent from the left May into the LAD. Of course, protect the circumflex branch, but hope that it will stay open, giving the almost 90-degree angulation, and that I would have a bailout strategy with maybe tap technique at the end. But I think having seen the CT, I get a bit more worried about the degree of calcification, and I'm thinking more, do I need to modify the lesion a bit more with IVL? In order to prevent actually shift of the calcium and occlusion of the circumflex. Of course, given the resolution of the CT, I don't know, is it calcium that's superficial? Is it deep in the wall? Is it some blooming artifact still? I would be interested to know how Bruno and the experts solved it, and how would you do it, Praveen?
Okay. So this is a very, very interesting situation where there is some difference between the CT angiographic image and the angiogram itself. And you rightly said that the calcium is not so visible on the angio rather than on the CT. So I think CT is very helpful. And in terms of choosing the devices and making a plan, so according to what I see on the CT and the angio now, the plan will be to definitely make it a single stent strategy because circ is looking all right. But certainly I will protect this circ with the pressure wire, because what happens is that it will continuously give me a surveillance of the circumflex through the entire procedure. And I'll only take the pressure wire out once the stent is placed from the left main into the LAD. That is number one.
But before the pot?
Before the pot, yes. And the other thing is that using a IVL will be certainly in my mind, and not using a rota because the lumen is reasonable. And also doing a cutting balloon after the IVL to have as much effect of preventing the side branch occlusion as much as possible, so that I avoid putting the second stent.
So what is very interesting that I didn't know that the lithotripsy, the shock wave can destroy the sensor, but if you put the sensor far away in the circumflex, it will not happen. That's for me what I learned today at PCR, okay? So now the next question is, what about the technique? This is your turn, Pruthvi, so you come here and I activate your slide, yeah? Just there.
Good afternoon, everyone. So we know Supraflex Cruz stent system has ultra-thin stent struts. It is 60 microns in thickness. The unique characteristic of the stent is that there are dual Z connectors which are going from crown to crown, forming a LDZ link. So the alternate LDZ link gives good flexibility and trackability. And these connectors are alternated so that you have a very wide cell, including 4 valleys. This slide shows the mechanical performance of Supraflex Cruz stent in comparison with other contemporary best-in-class drug-eluting stents. We can see that the optimal crossing profile is quite good, around 0.97 mm. The force shortening is quite minimal, it's around 1%. And the radial stiffness, when in the context of left main bifurcation, which is very important, that the radial stiffness is good. And we can see that Supraflex Cruz has better and larger radial stiffness when compared to other class drug-eluting stents. And the mean push force, the Newton force that is needed to push the stent across the lesion is among the lowest. And in the context of bifurcation, one important thing is the cell design. So Supraflex Cruz has in the same class the highest cell area to work with, which is very important in preserving the side branch. So, of course, in left main stem, we use stents of 3.5, 4, and 4.5. And Supraflex Cruz stent system, 4 mm stent can be expanded to 4.5 at nominal pressure, and it can be further post-dilated to 5.5 millimeters. We can also see that 3.5 millimeter balloon can be, stent can be expanded to 4.25 mm. So one important thing is what happens when you expand a stent above its nominal pressures. Is the radial strength remains the same? So bench tests have shown that in fact the radial strength of the Supraflex Cruz increased when dilated to maximum expansion diameter as compared that at the nominal expansion diameter. Thank you.
Very good. So very good. Now we have in the panel Praveen Chandra, and he has 3 slides on what we know about the ultra-thin Supraflex Cruz in main stem. 3 slides, yeah? You activate, you see your name there. Yeah.
No, this one.
Above,
yeah,
above. Yeah, this one. Yep.
Yeah. So, as you can see here, I'm going to share with you whatever because we started using this stent maybe more than 10 years back, and this is a Supraflex family of stents. It kept and having some improvements at different points in time. And this is the number of patients who were treated. You can see here from 2012-13 to about now 23, and many of them are registries. And these registries, these were the number of patients who were actually treated for left main disease as well. And from the randomized trial, which was in 2019, the Talent showed again 15 patients who were there in this trial for the left main treatment. So this is the information which we have gathered here. And the 12-month clinical outcomes you can see here for the left main in these patients, and these are the total number of about 8,000 patients of these studies. And here you can see that 92 of them were left main, and here the TLF was 4.09%, and the clinical indicated TLR was 1.59%, and stent thrombosis was 0.66%. So this information was very, very positive from these studies, registries, and then now we have, now the newest data, which is going to be much more in detail now, but here we have the information of about 53 patients from the multi-vessel talent trial, which is going on in Europe at this time, and 1,000 patients have already been enrolled. And these are 53 patients who were actually then compared, and these are the two stents which are being compared, the Supraflex Cruz, and this is the Boston Scientific Megatron or the Synergy stent. So here you can see that most of them were actually, here you can see the LAD extended to left main, which is a very common thing. And this is what we are addressing today, that if we extend these stents, how far we can go with the expansion limits, and then how much we retain the strength of these stents and the outcomes. And then LCX extended to left main is again a common situation which we see. Distal left main was treated in some patients, and the left main bifurcation was almost negligible in this because these patients were not in this analysis. And you can see that the various type of combinations were done: kissing plus pot, only pot, and all those, these combinations. And here you can see that this information is quite positive at this time, and certainly we'll have much more information subsequently when the whole study data is collated. Thank you.
Excellent, Praveen, excellent. So now we have seen enough slides, Jean. I think it's time to go to the lab and call Bruno. And
Patrick,
question?
The two questions concerning the stent itself, the presentation of the stent. The first one is after maximum expansion, what happened to the polymer and drug release?
Yeah, I mean, I can answer that because I think that what is very important is that through the structures, this ring became very circular. So you have seen there is, at least from the mechanical point of view, an increase in radial. And of course, like every company, they have checked the integrity of the coating, and that's quite reassuring. We have no slide to that today. We should have thought about that. But I can tell you that what I've seen is quite reassuring. Okay. Yeah.
And the second question concerning the device itself, how about its longitudinal strength?
Alors, you have seen that on the slide. Maybe it went a little bit fast, but let's say that 1.2% shortening is what has been documented in the so-called ISO test, the test that you do on all tests. So I think that's a general percentage, but it's valid for almost all length and so that's also pretty good. I think it's in number 3 position compared to all the stents that we have. So very, very close to the best in class. Yeah?
Excellent.
Let's go to Bruno because he must be waiting now. Huh? We are on time. Good news.
Okay. So welcome to Clinic Pasteur. All the team is ready. We have heard already all the comments done by the panel. We have not seen in front the image of the MSCT, but I have seen it before, and it's a fantastic image that you have presented. And now we can go live. So the topic of this of today is to perform a distal left main PCI using the Supraflex Cruz stent. We have as a guest Professor Onuma, who will be there to do the OCT at the end of the case. Next. So the key objective of the case first is to perform the distal left main PCI using the Supraflex Cruz stents to appraise how the new technology of MSCT can gain left main PCI, but I think that you demonstrated already perfectly. And after, to review what are the post-PCI OCT parameters to achieve for the safety of the patient. So the procedural strategy, we choose a 7 French guiding catheter because it's a left main, quite large, and so we will be more comfortable with a 7 French guiding catheter. We have a protection wire in the left circumflex. Due to the evaluation by MSCT, we decide to do a plaque preparation of the calcified lesion using a shockwave balloon. Then we will do a stenting left main LAD with a Supraflex Cruz stent using, a provisional strategy with probably a pot, with surely a pot, kissing and a final pot, and do a final OCT evaluation. This is the strategy. It could change during the life, but that's what we intend to do. So about all the tool and technique, we will use a Shockwave 4.0 millimeter balloon. We will address that because the MSCT side maybe, you know, the left main was 4.25, the LAD was 3.0. We have reviewed the angio and discussed with you why we will choose the 4.0. Then the Supraflex Cruz stent, and then do the OCT with the Terimo of the eye system. So I think that now we are in 7 French, guiding transvagal approach. Now we can review the angio, and I will let my partner, Antoine Sauguet, to comment this angio.
So you could see on the angio that the left main is quite long, and there is a long calcification across all the left main, except the ostium of the left main, and it involved the bifurcation. And there is no disease on the proximal LAD and no disease on the proximal left circumflex. Next one.
This is the spider view.
We try to perform the spider as the CT mentioned with left 50 degrees and caudal very close to 35, and we could see that it was the perfect alignment to see the distal left main, and it confirmed that there is no disease at the ostium of the LAD, and as Bruno mentioned, we have the feeling that at the angio, the diameter for the LAD is closest as 4 millimeter than 3.5.
Maybe we can review that on the next view. It's the standard view to see the LAD. Okay, please. Okay. Okay. So you see, this is really what maybe changed a little bit more our strategy. We have the feeling that the LAD was above for us, and with our angio-guided eyes, is close to 4.0 millimeter. And probably using a 4.0 millimeter shockwave was maybe a better idea. We see that there is some mild atheroma at the level of the mid-LAD with this ostial lesion of the diagonal. But I think what we change a little bit compared to the data of the MSCT is we increase a little bit the diameter of the shockwave balloon. Initially it was 3.5, but due to the angio, we moved to the 4.0. So if you agree now, we will move to the plaque preparation with the 4.0 shockwave balloon. We have already put the 2 wire, as you've seen. So the first step is to do this plaque preparation with the 4.0. So I don't know, Patrick or Jean, if you agree with this modification of the strategy.
Yeah, I think it's you know, the multi-slide CT scan is very reliable if there is no disease. Okay, that's pretty sure. You saw the origin of the main stem, 16 millimeter square. When you have a lot of calcium, there are what we call the blooming effect, and then you may have some underestimation of the vessel area and overestimation of the narrowing. So you have to take that into account. Don't forget that this multi-slide CT scan is there to make the diagnosis and to make the planning. You are prepared, you know what you're going to find more or less, and then because you are prepared, you know what to do. You can modify your strategy, but you have already the good projection. You saw the projection was spectacular with the circumflex completely separate from the LAD, a maximal angle that facilitates. Tell us what you are doing, yeah?
So the shockwave 4.0 millimeter balloon is in place, so I will inflate it at 4 atmosphere. It's the standard, and I do the first inflation. So when we are at 4, then we declench. Okay, so it's 10 pulse. You see, we are looking at the pressure, and it's still good. After the 10 pulse, okay, we increase at 6 atmosphere. We don't see major waste. And then we wait to deflate a little bit. Okay.
We use a shockwave C2 plus, 4 millimeter in diameter by 12 millimeter for the length. And we decide with Bruno to use the 12 cycles of 10 pulses for the patient and to perform a little overlap of 2 millimeter for the balloon.
You see
Sorry, Bruno. It means that we will perform probably 6 cycles at this place and pull back a little and perform 6 cycles more proximal to the left main.
So I do already 2 cycles, and you see there is a good hemodynamic tolerance. Hopefully, we have also with us the anesthetist who is looking for that. So I do the 3rd one. I inflate to 4 atmosphere. Maybe you can, have the, and then I activate for 10 pulse. You see there is no major waste. Then I go up to 6 atmosphere. I wait a little bit, and I will deflate the balloon.
So Bruno, during the balloon inflation, there is a question coming from the audience. It seems that there is a filling defect very close to the ostium of the L circumflex on the angio that you show. Can you tell us?
Defect, during the shockwave balloon, you mean?
No, before, on the angiography that you show. Particularly, I think it was in the spider view.
Probably.
A kind of defect there. You can see that was not on the diagnostic angio initially, so that's me.
It was surprising.
A new component. I mean, we have to pay attention to that. You can see you suspect on fluoroscopy the calcium at the upper part of the balloon now.
And you see that the balloon is pushing a little bit the calcium. So we have done already 4 cycles.
We could perform 2 cycles more. We could discuss what to do in case of decrease in the pressure, and if the patient not tolerate the inflation of the balloon in the left main, we could divide it at 5 pulses and deflate the balloon and not deliver the 10 pulses for the patient.
But for the moment, the hemodynamic tolerance is good. We see on the ECG some modification, so probably we will leave a little bit the patient to recover. It's important to notice that. Okay. We have already done 4, maybe 4 is, it's okay. We will wait a little bit.
Bruno, what is really important with the shockwave balloon is not to deflate during the delivery of energy and wait a little couple of seconds before deflate the balloon after stop delivering energy.
Concerning the shockwave balloon, there was a question which is the following: how to make sure that 10 pulses are enough to go for more?
Well, I think that first, you see, it's like a standard balloon. If you don't have any major waste on the balloon, it's okay. So I think that we don't see any major waste on the balloon. We will see. Maybe you can zoom on that, but I will inflate the balloon a little bit now at 4 atmosphere. And you see, I will deliver. We are a little bit more proximal.
I pull back approximately around 2 millimeters, because we know that from the distal marker of the balloon to the marker who delivers the energy, there is 4 millimeters and 6 millimeters between the 2 markers, and 2 millimeters at the distal part, at the proximal part of the balloon.
Okay. I will re-inflate. I wait a little bit to, looking at the ECG. 4, okay. Okay, I do a...
We know we could magnify on the image, probably.
We will wait. Okay. You want to magnify? Okay.
Yes.
Okay, we'll do once again.
We'll see, because sometimes we could have some movement of the calcium when we inflate the shockwave balloon.
Okay.
Especially when there is a big amount of calcium.
There is still indentation.
The tolerance of the patient is quite amazing, and there is even some adaptation. The blood pressure is now higher than during the first, the second, and the third inflation.
But we have the anesthetist with us.
I know the cath lab, but it's certainly due to the presence of the anesthetist in the cath lab.
But now we have change in ST segment, transient, we hope.
We have ST segment. That's why I'm waiting a little bit more between the inflation.
And you could see that there is a resolution of the ST segment. But anesthesiologists didn't put some drug infusion for the patient.
Okay, we inflate. Let's see.
So how many inflation you are doing in general? I mean, I think we are already number 6, if I'm not wrong.
A little bit more.
Here we are at 9 cycles. And normally we try to put all the cycles for the patient.
If possible, we do all the pulses that we can give, because we have seen in the last French registry that one of the key success of the procedure was related to the number of pulses that was given. So in fact, we try to give, if possible, all the pulses that are available. 4 atmosphere, okay? So we will do maybe at 10 it will be enough.
Yeah.
That's interesting, because we usually stop when we have full expansion of the balloon, but you keep going further.
Yeah, that's right.
Yeah, as Bruno mentioned, in the France registry, it decreased around 86% the target vessel failure when we deliver all the cycles for the shockwave balloon. Okay.
So we will remove the balloon and then make an angio to see what is the actual effect. Normally, after the shockwave balloon, we are directly going to the stenting.
So we will see if nothing has been dislodged in the direction of the circumflex. That's really the question.
Yeah.
ECG looks fine, so should be just something not major, but you can always expect some mobilization of some material, calcified material. Yeah, it looks very nice. It looks very nice. I mean, I know people would say this is a stand-like treatment.
Yeah, leave it like that.
With done. I mean, you know, everything is possible. I mean, people are already doing drug coating balloon in the main stem. So, you know, if you don't want to put metal there, why not? I mean, we have a colleague in Korea which is doing. There's a little bit a remnant of contrast just at the ostium there that we have to keep an eye that we don't generate a dissection at the ostium.
Okay, I give some nitrate, sorry, just to look at the ostium of the substance.
The ostium has paid a price there. It was not visible, but in spite of you, it's clear. Something happens,
There's some...
correct.
Okay.
So the next step will be now to stent the left main circumflex, if you agree.
What about any imaging at this stage?
I think that we have done. I think for me, we'll look at the left main.
We do after. Maybe
after. Well, I think that here the result of the left main is okay. Huh? Okay. So maybe we can do the left main stenting the lady.
And we choose with Bruno to implant Supraflex Cruz 4 millimeter by 28 millimeter
24
length.
Maybe 24, because remember we will go deep in the LED. I think
the shockwave balloon is 12 millimeter,
and we use
probably enough. 24,
20, even 20.
Do you plan to cover the ostium of the left main?
In fact, no. For this particular patient, because this patient has mild aortic stenosis, 1.4 or 1.5 centimeters per square. So for the future, if he deserves any TAVI procedure, if we have some protrusion of the stent inside the aorta, the stent could be crushed during the TAVI procedure. So for sure, for the moment, it's not an issue, but maybe in 5 to 6 years, if there is a stent across the aorta, when we will do the TAVI, this could be crushed. So I will here try to respect 1 or 2 millimeter inside the left main, due to the fact that maybe in the future it will require TAVI procedure.
Bruno, 4.0 by 20.
20 by 20. We will be a little bit shorter compared to the recommendation.
That's a good point of consideration, the fact that there are already 23 millimeters of mercury has gradient on the aortic valve. So despite the fact that it is 81, you know, these days there are individuals in the 90s who get also a valve. So I think it's a wise decision to try to avoid the ostium. And there was a little bit contrast but I didn't see in that projection. I think that that's quite reassuring.
It was on the previous view,
Yeah.
But we'll see after advancing the stent. Huh?
Yeah. So there is.
So after we will use. Yeah.
Yeah, go ahead.
So sorry, I will. Okay, put the stent.
So while they are wiring, I think that without any conflict of interest, we can say that the shock wave is really making a major entry in interventional cardiology. And for those who are a little bit interested by the marketing aspect, if I can so, there is a battle right now between Boston, Johnson & Johnson, and Medtronic. Yeah. The discussion with Boston has been stopped, but I'll continue with Medtronic. So we will see. But it's amazing the impact that it has. I've seen, I think, an increase of 72% in the use of these technologies. So, and once again, I've absolutely no conflict with this technology, interest with this technology. Okay, the stent. Oops, okay.
The stent. So it's a 40 by 20 millimeter length.
Yeah.
Supraflex. Okay. Maybe you have to advance it a little bit. You see, 20 was enough for me. Huh? Hope we will not have a distal dissection, but I choose the 40 due to the. Maybe we have to advance a little bit more.
Yes.
Yeah, definitely.
If we don't want to cover the ostium. Huh?
Advance.
We see the
up to the calcification, I would say.
We see the image, the contrast on the top of the left main.
This is not so bad, I think. Maybe we can pull back a little bit just to control this image. Probably due to the guiding, yeah?
Could be, just over there, Bruno.
Yeah.
Okay.
Yeah, that's correct.
That's good.
Yeah.
How does it look in the cranial?
Yeah, okay, I will do, okay.
And Bruno, you will not inflate at
8 atmosphere.
8 or 10. 10 is quite nominal.
Yeah. Okay. So we nominal, then we will remove carefully the balloon in order to avoid a deep engagement of the guiding, because at this moment you can damage a little bit the proximal part of the stent. So you have always to remove that very carefully, especially when you deal with a very large stent. Sometimes. Okay, let's see what is the result for the moment. We don't see any ECG modification. Okay, for the moment, so far it's gone well. Maybe we can go to the first to the LAD to see if there was no distal dissection.
4,5-12.
4,5-12, yes. Okay, let's see. Okay.
It's only the spider view which give you a good
no,
information.
But what I want to check the LAD distal to the stent to be sure that there is no distal dissection.
Yeah.
This is correct, and we will go now to the effectively to the spider view, the 50-35, if we can. Okay.
So I found the information of Praveen really interesting, that before doing the pot to have this pressure wire there, and then if it's okay, you pull out and then you do the pot, and you have heard that you can do lithotripsy along the pressure wire, that it will damage the sensor if the sensor is close to the shock wave, but not if it is far in the vessel. I really learned something today, yeah?
We could also do a QFR.
Yeah. So in many cases where we did the IVL on the pressure wire, especially in the LAD, there was no problem. But then when the pressure wire was in the side branch and we are doing IVL, then the pressure wire sensors would just go away and no tracing could be found.
Okay. So we are looking very carefully now to the ostium of the circ. But there
It's
will be
not so bad. There is no worsening after the stenting. We have approximately the same aspect that after the shockwave balloon. So in fact, the stent was quite conservative to this image. And now the next step is to do the pot with the 4.5 12 millimeter balloon. Maybe you can advance. I think we are close to the. Okay, we will film that. What we try to do, I think it was not so bad. Close to the carena, if you agree.
So this is really a critical moment, Jean, because either this ostium of the circ will be somewhat improved, through the pot, with some struts in the direction of the ostium, or there will be some deterioration. That's really a critical moment in the procedure, because you can get engaged in the two-stent technique, not because you want, but because you have been provisional until now. And if you are forced to do something in that direction, no, there will be no argument, it will be done, But if it is acceptable, I mean, it depends very much of the type of flow, length of dissection, irregularity of the lesion.
Absolutely.
So just to explain what we have done, we do the pot with a 4.5 millimeter balloon, and just after we do a stent enhancements acquisition. As you can see, I think you can see the stent enhancement. On peut monter le stent vis, vous l'avez? Did you see the stent technology? So you can see that the stent is.
Non, ils l'ont pas, je pense encore. C'est possible de montrer le stent vis, s'il vous plaît?
La régie. La Stent technology sur la droite, stent view, là, perfect. This is a cheap imaging to see the geometry of the stent. And you see that the stent is well deployed at the level of the LED. We see the calcification on the roof, and we see the degree of post-dilatation at the level of the left main. So I think that this image is, for the moment, quite satisfying for the left main and the proximal LED. And I think that now the next step is to maybe recross toward the circumflex to do the kissing and probably a final pot.
A small additional point is that the remnant of the contrast is behind the struts.
Yeah.
That's good. That's good.
Yeah.
Probably you have sealed some kind of dissection there, just enough.
Correct. So you have the wire. So the next step will be now to recross. So what will demonstrate Antoine is to go toward the LED with like a loop, and then to try to jump in the distal cell of the stent to go toward the circumflex. That's the plan. I will say that's what we try to do. I hope that we will be successful. Okay. So first of all is to go in the LED, if possible, with a like this, with a loop. Then we will try to detighten the loop and to jump inside the circumflex like this. So we are sure we are in the good part of the stent like this, and then to re-advance. So probably there is here. It's a matter of time sometimes. Okay.
Trying to get through the distal cell.
Yeah, that's to get the distal cell, yeah. Maybe it's a little bit more.
Or we could change in the view of.
You want to do another view?
Sometimes the loop creates too much kinking in the wire, and then it's less steerable, I would say.
Yeah. But with time, okay.
There we go.
Close to the exit. No.
Take care.
Yeah. We could change to the spider.
The spider view,
Yeah.
Would help because
I agree.
there is a real stenosis after the angioplasty left main to LAD.
Let's see. Okay.
Just a little test, Bruno.
Okay.
Okay.
Maybe it's a little more
Yeah.
distal. It's a matter of patience. So the circumflex is patent, so really we don't need to worry. Yeah. Okay, we are close to the. No,
No.
it's too proximal. Here it's
Too proximal.
so actually the wire is a standard wire, correct?
Yeah, yes, it's run through.
Maybe we can change
change.
for a Sion blue, something like
Sion
that.
blue or filter.
Filter. Sion blue. Give us a Sion blue. Yeah.
Un petit test.
Okay.
Yeah, this is better.
Okay.
Test.
Okay.
Non, c'est bon.
Yeah, that's it. You know, it's just a matter of patience. Really, it's the part of the situation, the case of the procedure that you have to take time. There is several parts where we have to take time. When we remove big balloon from the left main, because you can have a deep engagement of the guiding, and you can crush the stent. There is this part also. It's a matter of patience.
Alessandro has a question. He's from your lab, so...
Yeah, may I ask you a question to Antoine? So, Antoine, do you have any tips and tricks on how to pre-shape your wire to facilitate the access to the side branch?
Yes, in this case, I have the feeling that the angle is very close to 80 degrees, and that's the reason why I put two different shapes. One very short, with around 45 degrees, and the second one very close to 45, and it means that the two shapes are very close to 90 degrees.
So maybe
but
now
two different shapes.
You remove.
Now we will remove the first wire on the left circumflex.
And once again, you have to take care.
To be sure that the guiding catheter doesn't engage too much the LA
you see,
left main.
The guiding catheter was very stable. He made some counter pulse on the guiding in order to avoid a deep engagement. And now we will advance a 2.5 millimeter balloon for the circumflex to do the kissing, and a 3.5 for the LAD, probably, or 4.0. I will say maybe 4.0 for the LAD.
2.5 for the left circumflex, and 3.
Or 4, maybe we can
3.5.
3.5, okay, 3.5. Twist, find me.
It's always when you try to change the wire, then it costs, That's the kind of mysterious things in interventional cardiology. I'm going to change the wire, and at that time it's going to...
Like the wire feels the pressure.
Yeah, that's the
I always say to the nurses, please start to threaten me with something. No, but I think the tip with wire shaping is, we used to call it double Japanese hook, and I think that's a really nice one for technical detail. Yeah.
But you know, in this case, you realize that the wish to go to a distal cell of a proximal cell is quite idyllic, I would say, but not always realistic. So it's here, and they were happy to wide the vessel without being too selective in selecting the cell,
Without causing a
I think we are making serious progress now. Any question, Jean, that from the auditorium?
There was a question concerning the plaque preparation for Bruno during this time Antoine could work. Well, it was concerning the indication of rotational atherectomy in this particular anatomy.
Yes, I think it's a good point, and we can discuss both techniques. Yes, I think that usually we will select IVL when we have large vessel and quite short lesion. This was, I think, an ideal case for the IVL, and we still use the rotablation for long lesion, especially very tight and long lesion, because here we know that due to the profile and the length, the short length of the IVL, then we will have some difficulty. So clearly, large vessel, short lesion, it's IVL, long lesion, and smaller vessel, it will be a rotablation. Yes, you can see we use here a non-compliant balloon, and there was no difficulty to cross toward the circumflex, even with a non-compliant balloon. So it means that the pot have been correctly done, and also the performance of the stent, for sure.
There is a question which is not the case today, but if we had to perform IVL in the circumflex, what kind of wire do we select?
You mean, okay.
In other words, talk about the support of the wire, the backup of the wire.
I think
do you need a special backup for a shock wave or not?
No.
Okay. Usually I use my standard wire, but effectively the profile of the IVL is not optimal. So you need to have a good support. But what makes the sense is the guiding catheter, and also the maybe sometimes you need to do some preparation with a 20 mm balloon. But the wire could be supportive, but it's not a main issue, I would say.
On va passer peut-être en spider. Juste pour
Okay.
But in
So
case of failure to go across the lesion with the IVL and with the conventional wire, as Bruno said, we could perform some predilatation with a very small balloon, 2.0, before the use of the IVL balloon.
Okay, I think that we can advance a little bit the circumflex balloon just to be sure. Okay.
So Bruno gave very clear answer about when to use the rotablator and when to use something else. In terms of OCT, we will not see that today, but the appearance be after rotablator, after orbital, after cutting balloon, and lithotripsy is quite different. I mean, you see really trenches with the cutting and with the lithotripsy technology, while with the rotablator and the orbital, it's more a knife cut in the plaque, quite concentric. And
in general, with rotablation, it's more superficial, the calcification, and with the rotablations, with the IVL, sometimes we can treat some deeper with the calcification.
I have seen the combination of both. I've seen a very severe calcified lesion, first a small burr, 1.25, and then they were able to advance the shock wave, which is a little bit bulky. I mean, we have to say the thing like they are.
You know, here you had enough lumen to put your IVL balloon immediately. I mean, if you were to do this with rotablation, you would have to go to 1.5 and 75 burr, which will cause a lot more embolization, etc. So I think it's a neat way to do it with the IVL. But as you mentioned, when it's an extremely tight lesion, you can make a progression from one to the other. Yeah.
What I like in the situation already now is that the contrast go briskly in the circumflex. You don't have any slowing down of the contrast. I mean, that's already always a good information, yeah. And it's very short. The abnormality is very short, so might be fixed with the balloon. Yeah?
I think that the result for me is not, I would say, perfect, but it's satisfactory if we want to do provisional strategy. I think that we fixed the left main. We have a nice result on the left main LED. There is some residual stenosis on the circ, but it's not, really critical. There is no evidence of dissection. What I suggest is do the final pot with a short balloon in order to be in front of the carina, then to do the OCT imaging and see with the OCT what we see on the ostium of the circumflex.
If I may add something, I would say that it's really interesting to see the sequence that you adopted for the kissing. I mean, you just postulated very well both the branches independently, and I think that this is very useful in cases like this when we have dealing with a calcified lesion on the main branch, and then you perform the kissing. I think that this sequence is also very interesting to see.
It's our standard of practice. Is to do sequential and then final. And what is important also is to deflate simultaneously the two balloons. Yeah. And as you can mention here, we use a 4.5 shorter NC balloon, 8 mm balloon, in order not to go up to the carina that we have done the kissing. It's just to reshape the proximal part of the stent. And if you agree, now we will be ready in the next minutes to do a final angio. And then we will have a short lecture about the OCT. We will do the OCT and show you what is the result of the OCT. Maybe now we do some angio to look how is looking the ostium of the circ. Probably the first one will be this one, but just for this. Okay, then we can go in the.
Looks good.
Okay, let's see now in this view the ostium of the circ. That's the main point. I think that for the left main LED, we see that the results are quite good.
If I have to make a guess, I think that with the OCT we could see a little bit calcium being pushed in the ostium of the circ. That kind of translucency might be. We'll see if Yoshi can catch there on the OCT.
That's an additional stent in the circ.
That's not too bad news, I think.
Yeah, if the lesion comes back, you have prepared your entry into the side branch, and you can always easily put in a stent later.
The big vessel.
Okay. So maybe Yoshi, you are ready to do your presentation about OCT. So we will leave the place to Yoshi, and then maybe we have to decide what to do on the ostium of the circ. Okay.
I have to do that from here.
Okay.
Let's talk about the role of the OCT in the left main PCI. So the first slide is, in general, what we could do with the OCT in the left main PCI. In this particular case, pre-procedural planning was already done very nicely by the cardiac CT angiography. So I will go to the OCT during the procedure and post-procedure optimization. Next slide, please. So the next slide shows that the after putting the stent with the provisional approach into the left main to the LAD, you do the recrossing, and if you are not sure about the wire position, it is good to see the OCT to exclude to avoid the external wiring. As shown in this video, you can see that the wire is completed outside of the stent, and if you do the kissing balloon, you can see that the metallic carina will be really pushed into the LAD. Go next slide. Other consideration is to look at the opening of the circumflex side branch, and in general, it's better to take the distal cell to achieve the optimal opening of the side branch in the end of the procedure. Go next. You can also look at the deformation of stent. In this case, we put the stent into the left main to the LAD. After recrossing to the circumflex, balloon didn't go through. I think in this case, the operator was very careful not to create this kind of deformation. But in this case, you can see that the formation longitudinal shortening of the proximal part of the left main stent due to the guiding catheter maneuver. Go next. In case of the calcification, maybe you need to use the adjunctive therapy. Go next slide, please. You can see that effect of the adjunctive therapy, such as the lithotripsy of the rotablata. Go next, please. For the lithotripsy, you can really see the breakage of the calcium, and also for the rotablata or the OAS, you can see that how much lumen was gained by doing the OCT after the such a procedure. Go next. In this case, I think what is most important is stent expansion and also the opening of the side branch. Stent expansion, because it is a bifurcation, it's important to create a fractal structure, and it's better to have assessment of the minimum stent area and reference area for each segment, in this case LAD and left main. If you cannot really do the reference area measurement for the left main, you could potentially use the absolute value of the expansion. This is a Kang's picture for the IVAS based on the IVAS measurement, 8 square millimeter for the left main, 7 square millimeter for the polygon of the conference, and 6 square millimeter for the LAD, and 5.0 square millimeter for the circumflex. I think go next slide. There might be some argument that this data is from the East Asian population. For the European patient, maybe you need to achieve a little bit more, so that the left main for the Excel trial, for example, aiming at the left main MSA of 8.5, also for the circumflex ostium 5.5. So maybe you could use this criteria. And go next slide. Just malapposition. Most of the small malapposition will resolve over the time, but if the distance is greater than 300 micron, length of the greater than 1 millimeter, you might consider additional post-dilatation. For the dissection, also the width of the distal dissection is equal or greater than 1200 micron, you might consider the additional stenting. So those are the points we should look at the post-procedural, post-stenting OCT. Thank you for attention.
Okay, thank
so
you
have, yeah, very good, Yoshi. That was very clear. So we have seen what you should see, okay? So you have a pre-knowledge of what you have to see, to look at. And now is Yoshi will have to make the comment. seeing for the first time the OCT. One guess, if you want to make one guess, is that there may be some calcium a little bit protruding of displays in the ostium of the circumflex.
I think they decided to stent the ostium of the circumflex.
The stent,
Side branch.
not crossing. Yes.
No. Okay. It's not crossing easily, so maybe you do not force. You have maybe to predilate a little bit more the ostium of the stent.
Yeah.
Okay.
Would you
So maybe
consider
go back
doing
to the-
IVL in the ostium of the circumflex, given there's probably calcification that's...
Not. I think the balloon was well open. What we will go back with a 3030 balloon, a little bit larger, and we go to higher pressure. In fact, we were going to 8-10 atmosphere in order to avoid the dissection. And what we are planning to do is to now go back with the okay. Yeah. So we go back with a 3-0 balloon, a little bit, it's a non-compliant, and we will go to higher pressure in order to fully open the struts. And for sure, I think it's not the strut of the cell, it's more the calcification, as you mentioned.
Yeah.
So I think we need more preparation here. Okay. Sorry, my eyes are now too old. Okay, it's okay.
You know, you have seen all the possibility of opening a distal, a proximal cell, and then you can eventually create a new metallic carina, and to rewire that or to cross with a balloon is not an easy thing. The people want to use drug-coating balloon after stenting. Bruno Scheller will tell you, be careful, because the struts is going to scrap the coating and the drug for the balloon. So there is still a lot of work to be done in that thing. But we are pleased to see that it is crossed now.
Yeah. No problem. I think we have to pull back a little bit. Okay.
Yeah.
Yeah,
On va reprendre un nouveau stent de 75. Hein.
De 75.
Ouais.
Okay.
We'll
So
inflate at 12 atmosphere with a non-compliant balloon,
Yeah,
3.0. 16
atmosphere. By experience, I know that if there is some calcification, the best is to go to very high pressure in order to, crack a little bit this. Maybe we have to check.
They are really a critical moment now. Either you change the anatomy or it remain identical, and then you can slowly but surely move to the strategy of two stent.
Okay.
It's not too bad, but I'm pretty sure there's a little bit calcium there at the bottom.
Yeah. Or maybe
Yeah.
is it a dissection down? Oh, maybe I don't know.
A combination of a
now
little
it's
bit contrast behind and a piece of calcium there. Yeah. That translucency is quite clear to me. Otherwise, the lumen is not bad. I mean, the flow is fast. Yeah.
Yeah, that's right.
But
I think that
the fact that there is a little bit contrast behind the plaque, that is
the best is to put a stent.
Yeah.
Okay.
Okay, you see, after doing a good preparation, and I think that's the main message. When you have a calcified lesion, you need to prepare the lesion. Whatever technique, but you need to prepare the lesion. And it's a clear demonstration. Here we have some difficulty because we were a little bit conservative doing the kissing. The rationale was not to create a dissection, but doing this quite conservative inflation, we have some difficulty after to advance the stent. So this was my mistake, and probably because we decide to put a stent, we should have go back with the balloon before advancing the stent. But sometimes you try to spare some time, and you are not perfect.
Spider.
Okay, we'll look in spider view. Okay. Pas de problème.
Okay.
Okay, what I suggest, maybe we can try to do and stand is maybe, okay, just to see if we are able to see. Okay, let's see.
Seems good, hein, Bruno?
Let's see.
We'll see with the stand vis.
Let's see. Can you see the stand vis? Okay, we are quite in maybe not so bad.
No, not so bad, huh?
It's very good.
It's okay.
Yeah.
Perfect.
Yeah. Okay.
Okay.
Yeah, it's like a tap technique.
Yeah.
So the way we look here, the marker of the stent and the position of stem, I would call that tap. Do you agree?
Minimal tap.
Of a micro tap?
Minimal tap.
Of a major tap? I mean, that's all the question. It's only the result we will tell us how far. But if you look at the last, just beyond the marker, is really...
What we have done is to deploy the stent at nominal pressure, then we pull back the balloon a little bit, so we are able to deploy at higher pressure, that is
12 and 12.
It's 20 now, and then, now we go to very high pressure in order to deploy completely the stent at the level of the ostium of the circumflex, and now we are ready to do the kissings at nominal pressure, both. So first step was to deploy the stent nominal pressure, then to pull back the balloon a little bit at high pressure in order to avoid the distal dissection, and then to do the kissing.
And then we will perform the repot.
The repot with the 4.5 8mm stent. First, we will do an angio to see that everything is correct down to the stent. So we have changed the strategy. Initially, we seemed to be provisional, but the result was not perfect at the level of the ostium of the circumflex. That's why we moved to the tap.
Wow. Nice.
Okay.
It's quite good, hein?
Yeah.
On prend le 4-0, le 4-8,
Yeah.
le 4-5-8.
Yeah, 4 minutes I can talk.
Et après, on va préparer l'OFDI.
Yeah. Vas-y.
C'est sûr, celui-là.
Ok, c'est celui-ci. Ouais. So, for 5 minutes.
So are you doing repot now with a very short balloon? Okay.
Yes.
Yes, 8mm balloon.
4.5 by 8mm.
Okay.
Yeah, I want to ask.
Okay.
What was the size of the stent? So the kissing was done with a 3 and 4.5? Or 3 and 4?
Yeah, no, the kissing was done with the 275 balloon of the stent and the 3.5 for the LED.
Okay.
2.7. Okay. Yeah.
6.5 double 13. Yeah, it's a little bit more than 4.
Par l'OFDI, ouais.
My feeling, but I am maybe, about my eyes are saying me that maybe the stent of the left main have been a little bit crushed when we advance the stent of the circumflex. It's my personal eyes, but maybe can you advance the balloon back? And I want to do a stent vis. We will compare to the previous stent vis, but I have the feeling that maybe the stent, despite our effort, let's see.
Some short.
Sorry, but it's my eyes who are speaking.
On voit sur le déjà.
Okay.
You can also do it with OCT.
Yeah, the stent has shortened.
You don't trust your eye.
The stent has been, I think the stent has been shortened.
Yeah.
Clearly.
Because you see that contrast.
Now the contrast. Yeah.
Bruno, before.
Yeah. So it's you see, we do all our best to avoid this, but this situation happens. So maybe we will need a short stent in front, 4.0 by 8, in order to correct this, because here the stent is not fully covered.
4 par 8.
You see, and once that's an important message. Each time you try to force during a left main stenting, you can have this problem.
Longitudinal compression.
Yeah. Stent. And that's, I think, a main message.
Jean, what do you think happens there? Because is that something which has moved forward, or is that something that has been shortening? pushing one metal in the other. What will be, because the picture of the boost stent is very clear. Huh?
Yeah, but I think it's a little bit shortening because we could see the, the image, more dense image of the stent proximal to the carena, and this is certainly the double layers of the stent. So maybe because the stent was not post-dilated enough with during the pot, because when you look at the size, it's at least a 3.5 or a bit more LAD in proximal. The LCX is around 3 millimeter. So we anticipate that the diameter of left main should be close to 5, 4.55.
So here we choose a 40 millimeter stent. We will, after maybe post-dilate with a 508 millimeter balloon.
Yes.
In order to reshape everything.
I think it's safer. It's a good option to post-dilate with the 5.0.
So this is the third stent? Is this the third stent?
Yeah.
We want to cover this small remnant of contrast there, definitely,
So this
without going up to the osteum. So it's,
A little bit in front of
It
the
moves again
carena.
this time.
It has moved.
Yeah.
Okay.
any question of the audience
Interesting,
by
because
electronic of going to the microphone?
5-0.
The stent is left main crushed, isn't it?
Yep.
Yes, I think we have the answer.
5-0.
Is it
I
a
think we will
longitudinal
use a 5-0.
stent compression?
Could be.
Could be.
Because we,
And
when
then there was
we
a
get
question
to
on the
Nice.
imaging in the LCX, but this will be later. We'll see later at the end of the procedure.
Yeah.
Yeah.
Well, we have to keep an eye on the time,
Yes.
because I think that
We have
I
maybe
think we want
time
to
just
see really the final result
OCT.
angiographically, and then at some point
Three of the eye.
we will have to short a little bit the program to be sure that we finish on time.
Okay, so come back a little bit like here. Maybe we can do a Stent V's acquisition. Okay. Strange.
Okay.
Is this a 5 millimeter balloon?
But it's interesting because when we get with the wire to reopen the left circumflex, we enter with the total loop with the wire. It means that we are really inside the stent.
Yeah. No, I think it's maybe when we try to cross with the stent of the circumflex, maybe here we push a little bit too much. Yeah.
Or maybe when they remove the stand of the circ, the guiding.
So what you can do is to do the
I think the
control angio now.
Yeah.
Yeah.
Okay.
Okay.
So now maybe we have time to do the OCT.
Not bad, huh?
Yeah.
I
And
like
you can
it.
do a CT,
I like it.
Yeah.
the run of a CT.
Okay.
Yeah.
You
Okay,
want to
OCT.
move to
Okay, so
Praveen?
let's go to.
So what you can do is
Praveen?
to you could record the run of the OCT. During
Yes,
this
and
time,
then
we have a
You have to-
discussion with Praveen, and we will come back
Okay.
to you
escape.
Okay.
in
perfect. So we have time to.
in 5 to 6 minutes. Is it okay?
Perfect. Okay, perfect. That's a good news.
Where's that?
Okay.
Okay, so I think, we are seeing such an interesting case. So I'll interrupt a little bit in between to show you a similar kind of case, which is, you see here, there is the long LAD lesion, and the plaque is extending into the left main. So, and right coronary is okay, circumflex is not too big, similarly as we have seen here. So the plan here again is to finish it with a single stent, but there are certain things which we keep in mind while we are doing this kind of case. And here you can see that, we are doing this entire case on a FFR wire, because the initial plan was to actually do a good balloon dilatation, cutting balloon, because it is a non-calcified, so no shock wave, and then probably leave it with just a regulating balloon. But of course, it was a provisional stenting to the LAD. So here, once we have done the balloon dilatation of the LAD, of initial 2 millimeter balloon, followed by a cutting balloon 3 into 15 into the mid LAD, and then we did the imaging. As you can see here, the imaging showed that the dissection is big. We need to definitely stent it, and the FFR was still 0.68, which means it is a flow occluding dissection. So this kind of strategy, which we use many days now, where we don't want to put a stent, and here you can see that this is the pre-stent IVUS. I think the picture is not very clear. The calcification was not at all there. It was a complicated long plaque extending into the left main. So we decided to take a stent. Now here the choice of stent is very important, and we had to take a stent which would expand, should have good expansion limits, because distally it is 3 and proximally it is 4.5. And so that is why we had to take a stent which had good expansion limits. So we took a 3 into 44 Supraflex Cruz from the left main into the LAD. And you can see that we are doing a post-dilatation initially with a 3.5 in the proximal LAD, and followed by a 4.5 millimeter balloon dilatation in the left main going up to the ostium. And this, after we did the dilatations, we again did a imaging with the IVUS to see whether the stent is fully expanded. We get a good luminal area, which was confirmed from the left main into the LAD. And this was a sequential dilatation, distally 3, proximally 4.5. And no stent distortion, and the lumen was quite good. This image is a little hanging a little bit, but certainly you can see. And we finally also did a OCT. So this was a complete evaluation which was done, and you see that the FFR has become above 0.9, and the entire vessel is well treated from the distal segment to the proximal segment, and we could achieve a good result with no stent distortion, full expansion, and going up to the left main to the LAD. So this is the experience which we are having when we go from the circumflex to the left main or LAD to the left main. We have to choose a stent which has good expansion limits. And ultra-thin struts works very well. Thank you.
Very well done. Very well done. A full, sophisticated evaluation of the case. There is a question on the screen there. The question did disappear, but the question was, are we ready to perform ad hoc PCI cabbage with only multi-slide CT scan evaluation? I think that was for Alessandro, no?
Yeah, so although I might admit that probably we're not there yet, I do think that technology improved tremendously during the last years. The quality of the image and the ability to assess the morphology of the plaque really are improved. And also CT offers, as we've seen today, the ability of providing a functional assessment. Therefore, I do really think that this approach in the future will change our cath lab planning, because this will really improve the way that we can plan PCI, and we could, for example, dedicate more space, more time to those cases in which we anticipate more complexity. I do think that this is going to be the future.
Very good. I think we are discussing the OCT coming on the screen. Let me react to your question. I think the slide is not there, but are they ready for the OCT? Do we know that?
I don't know. We can come back to those.
Yeah.
Yes.
Yeah, very good. So, angiography is pretty nice. Yeah. I still believe that we will see a little bit calcium at the origin of the circ, behind the struts, I hope. Okay, so I think that let's look at the OCT. A little bit malposition there. Yoshi, we are listening to you. If you can comment on online. I don't know if you are a good microphone because we don't hear too much.
I don't know.
Yeah.
Maybe, can you hear me?
You can, did you hear me? Do you hear me?
Yeah, small dissection.
Okay. Yeah, small dissection, but it's not big as we said, the 200 micron. It's less than 200 micron with a kind of the cavity, not the flap. So I think we can ignore that the dissection. It's most likely the clinically silent. And the opening of the circumflex, as we shown in the 3D, it's very good. And there's no protrusion of the significant protrusion of the struts. And you can see that in left main, the minimum lumen diameter was like a 10 square millimeter. So I think the expansion of the left main is good, and also the expansion of the LAD is good. It's more or less 10 square millimeter, 11 square millimeter. And distal dissection is small, so I think we can really finish this case as it is. There's a small malposition, but you can see that there was a 2-layer of the struts, so I think that's because of the overlapping of the 2 stents in the left main.
Okay, thank you very much for this evaluation. Maybe we can come back on the angio to see you the final angiographic result. Okay, here we have the final angio. The final angio. Maybe we can zoom a little bit on it. I think the result seems good in this view. You can see that the left main is perfectly open and the circumflex ostium seems okay.
Very good.
Next. This is in spider view. Once again, the results seems satisfying here.
Yeah.
Maybe small calcification, residual calcification at the level of the ostium of the circumflex. I will say that the angiographic so far is quite satisfying, and the result of the control of the OCT OFDI is also quite satisfying. There is a small distal dissection on the LAD, but not really. It's not really a matter of caution. And this small malposition at the level of the left main. We go with a 50 millimeter balloon up to 20 atmosphere. So I'm not sure that we need to do further more work. So I think it's time to conclude. It was an interesting session to do the distal left main. We try to remain provisional, but unfortunately we have not a very satisfying result. And then we have to deal with the compression of the left main stent, probably when we try to cross with the left main, with the circumflex stent, and we handle it with the additional stent. And finally, we have the beauty and the advantage of the Professor Yoshinobu to comment with the OCT, and you review with him the important criteria we need to achieve in order that the procedure will be safe for the patient. I'm quite sure we were not in the room that you have seen very nice MSCT image, and you are ready now to discuss for the future MSCT. Thank you very much. We were very happy, and also thank you for all the team of Toulouse, all the nurse and all the technicians that were there, and I hope that you enjoyed this case. Thank you very much.
Thank you very much, Bruno. That was excellent. I think it's time to show one slide. Somebody in the room asked, where are the evidence? So I'll show one slide about the evidence. That was the question. I don't have to repeat. You have seen all the potential. But the slide I want to show you, and that's the last one, is this one. Where are the evidence? This is a paper published this year in the New England Journal of Medicine. And if you look at the top here, that was CT versus conventional angiography. That means that one group get a CT, and then a conventional angiography, and then a PCI, and then a bypass surgery if the bypass surgery was necessary. So diagnostic, but also used before the procedure. Not a small number of patients, 3,561. Look at the time of the enrollment, 2015 to 19, 26 centers in Europe, in 16 European countries. It was supported by the European Union, the 2020 Horizon. Stable angina, suspect of CAD, at least 30 years of age, refer for conventional angiography with an intermediate pretest probability of obstructive CAD. Primary outcome, a classical maze. And you see two things. You see that after 48 months of follow-up, the curve diverged, not to the point that they are symptomatic, significative, but you see a 30% reduction between the red curve, which is the invasive coronary angiography, and the group who had before the coronary angiography a CTA, before the PCI, before the bypass surgery. So that's quite impressive to see a 30% reduction in MACE. What is also very impressive is the secondary outcome, because if you look at the major procedure-related complication, including diagnostic angiography, including everything, you have 1.9% of major procedure-related complication from the coronary angiography to the PCI to the bypass surgery. That's for the group with starting with conventional cine angiography. But in the group who had the CTA before, to make the planning, to become aware of the problem before doing to catheterization PCI, it was only 0.5%. That means a 75% reduction. That I can tell you, Jean, it will be repeat and repeat until the community became convinced. And my very last slide is for all of us. CTA is a safe alternative to cardiac catheterization for patients with suspect CAD that will likely change clinical practice worldwide by replacing invasive testing in patients with stable angina with an intermediate pretest probability. That's marked the way the chairman of the trial in Charité in Berlin. And then 2 questions for all of us before leaving. Multi-slide CT scan, a game changer that may change the gatekeeper. Go tonight and think about that.
Great question.
Is the gatekeepers will be the radiologist, the cardiologist, hybrid, the non-invasive cardiologist, the general cardiologist, the general practitioner, or will the interventional cardiologist remain the gatekeeper? That's a challenge for us, and I hope we will reconvene in 5-10 years to see what we are. Thank you very much for your attention.